First, I'd like to thank everybody coming here on a rainy night, and also Pam for invitation and the Cancer Wellness Center for hosting this event. What I thought I would do is go over a couple of things that I usually go over with my patients when I see them in the clinic, and telling them what a peripheral neuropathy is and how it affects their life, and what are the things that we can do. So this is kind of the outline of what we're going to do today. I will talk a little bit about how we work up people with peripheral neuropathies, and then how we treat. And at the end, I have a few slides to talk a little bit about the research that we're doing with the help of the foundation. So peripheral neuropathy is a very generic term. It just means a disease of the peripheral nerves. And what are peripheral nerves? Peripheral nerves are literally like electrical wires. They connect your brain and your spinal cord to the rest of the body. It's almost like a little very fine net that spreads from the spine to all the arms, legs, as well as the trunk and face. So when we talk about peripheral neuropathies and peripheral nerves, we clinicians think in terms of the types of the peripheral nerves. The motor nerves are the ones that goes to your muscles and allow you to move your arms and legs. The large sensory nerve fibers are the ones that goes to your joints and give you the perception of balance. So even if you close your eyes, you know your hand is here or your leg is in one place. That's the job of those nerve fibers. When those nerve fibers are not functioning properly, you will experience imbalance. So people with peripheral neuropathy that involves these nerve fibers often walk like a drunk. They have poor balance. Majority of the people with peripheral neuropathy have symptoms of these, what we call small sensory nerve fibers. These are the nerve fibers that goes to your skin and give you the perception of touch, temperature, pain, and so forth. When those nerve fibers are affected, you can experience all sorts of unusual sensations. Prickling, tingling, pins and needles, sometimes sharp electric-like sensations, or it can be a burning sensation or an ice cold sensation. Sometimes the sensation can be even more complex. I had a couple of patients who felt like water was running down their legs, or there was something constricting their legs. So those are all sorts of unusual sensations that you can experience if these nerve fibers are affected by the underlying disease. The fourth group of nerve fibers are what we call autonomic nerve fibers. These are the nerve fibers that goes to your internal organs, to your blood vessels, and they're responsible for your bodily functions. So when those nerve fibers are affected, you may experience persistent nausea, vomiting, diarrhea, constipation, or problem with your blood pressure control. So if you're feeling lightheaded every time you stand up, it could be from that. Or if you have incontinence, and in men, it can be a cause of erectile dysfunction. So what is the structure of a peripheral nerve? As I said earlier, peripheral nerves are literally like electrical wires. In an electrical wire, you have the copper portion of the wire that actually conducts the electricity, and that's we call axon. Okay? When you blow up a nerve, so this is a big nerve that might be in your arm. Within each nerve bundle, there are organized into what we call fascicles. So this is, for example, this group of nerve fibers could be going to your thumb, and these could be going to your index finger, these could be going to your middle finger. Within each of these bundles, you have literally hundreds and often thousands of these small nerve fibers and the axons. And it's like the electrical wire that has the insulation, plastic insulation. We also have myelin around those nerve fibers. So not every fiber, nerve cell, will have a myelin, but majority of them will do. Especially the motor nerve fibers and the nerve fibers that goes to your muscles and joints and responsible for your balance. 95% or more of the neuropathies affect the axon. This is the type of, when the neuropathy affects the axon, that is the copper portion, that's often is not very reversible. But a small percentage of the problem is within the insulation around the myelin. Those often are reversible types of neuropathies unless they're inherited. And I'll come back to that. So what are the causes of neuropathies? As Pam mentioned, diabetes is probably the single most common cause of neuropathy. she mentioned that there's about 20 million people with peripheral neuropathy in this country, and if you take 100 people with neuropathy off the street and look at the underlying etiology, diabetes will be 50% of it, single most common cause. And then you have different types of underlying illnesses, and I'll come back to these later on in more detail. This could be inflammation in the nerve, it could be toxic from medications or from alcohol, or sometimes too much vitamins. For example, vitamin B6 can be toxic. On the other hand, too little B12 can be bad for your nerves also. Or you can have inherited neuropathies, where you have different genes, and then the inheritance pattern can be very different. Autosomal dominant means 50% chance each child will have the disease. Autosomal recessive means only 1 in 4th chance for each children. So you have 25% chance you inherit one bad copy from each parent. Or sometimes it can be what we call X-linked. That is, the woman will have the disease, but they will not manifest it, but they will pass it on to their sons. As she mentioned, about a third of all neuropathies are unfortunately classified as idiopathic. So idiopathic is a fancy word for medicine does not know what caused it. There's idiopathic form of every disease that you can imagine. Idiopathic hepatitis, liver diseases, kidney disease, heart diseases. Our goal is really to reduce the percentage of the cases that we classify as idiopathic and try to understand. And peripheral neuropathies can come in many different forms. It can affect your body in very different ways. This is probably the most common, where it starts in what we call glove and stocking distribution. The reason for that is, in most peripheral neuropathies, the longest nerves in the body, the ones that goes to your feet, the ones from starts in your lower back all the way down to the feet, are often the most susceptible to injury. And this injury can be chemical, it could be toxic, or it can be physical injury. Often, it starts in the feet and slowly moves up, and by the time it gets to your mid-shin level, it starts to affect the hands as well. So this is the most typical type. But sometimes you can have inflammation in the blood vessels that affect the nerves, or you can have certain types of infections, such as leprosy, for example, which is a very common cause of peripheral neuropathy in the developing world. You can have the nerves affected in a very patchy manner. So it can affect only half of a hand, thigh, or only 1 foot. So this is not very common, but majority of the patients with peripheral neuropathy will have this. So when we see patients, I go through a series of questions trying to determine what type of nerve fiber is affected, because it's going to help me understand the underlying cause. Because some types of neuropathies affect mainly the motor fibers, sometimes they affect mainly the small fibers. And there are 2 types of symptoms that you get from neuropathies. What we call positive symptoms are the ones when the nerve is active. For example, when we talk about these nerves degenerating, we're actually not seeing the degeneration of the whole nerve. If the whole nerve completely degenerates, you would just have lack of sensation. But what happens is a nerve that is partially degenerated and no longer is connected to your feet, for example, but the rest of the nerve from your ankle up to the spine is still intact, that nerve becomes electrically unstable and sends impulses to the brain when it's not supposed to. And those are the ones that causes these painful paresthesias, unusual sensations, pain. That comes because of this excess spontaneous electrical activity in the nerve. That's why the drugs that we use to treat epilepsy, like Lyrica, gabapentin, and so forth, work for peripheral neuropathies. When the nerve completely degenerates, you'll have numbness or lack of sensation. And often in patients, you may have both of them at the same time, because nerves degenerate at different rates. So you could have a patient who wouldn't notice if they stepped on something sharp and injured their bottom of their feet, but yet they have pain in that foot. It's very common. So you have to be very careful checking the bottom of your feet if you have that degree of severe neuropathy. When the large sensory nerve fibers are affected, you get poor balance. There's really no positive symptom of that. It's not like if it's very active, it's going to throw you off your balance. It's because of the lack of input to the brain. When the motor nerve fibers are affected, typically you get weakness and muscle atrophy. Muscles shrink and then you won't be able to move. In most typical peripheral neuropathies, when it starts in the feet, the first thing that you will notice is often tripping. So when you're walking, you trip because you're probably developing weakness of your big toe that catches the ground. And then later on, you'll have weakness of your ankle, so you won't be able to clear the floor, and again, you tend to trip. Usually, people with peripheral neuropathy do not develop weakness of their proximal muscles. Those are the muscles that allow you to go up and down the stairs or walk. So often the muscles above the knee are not affected, and that's not a big problem for people with peripheral neuropathy. But what they are often bothered by are these. They get cramps and fasciculation. These are little twitches in the muscles, and they can be quite painful. But there are certain things that also make these worse. For example, if your electrolytes are off balance, like if you're low on calcium, magnesium, or potassium, or if you get dehydrated, you tend to develop more cramps. So there's certain things that you can do if you have a lot of cramps to alleviate some of the symptoms. When you have autonomic nerve fiber involvement, you can either develop diarrhea or excessive sweating. These are often more common in diabetic patients, especially people who've been diabetic for 10 years or longer. Or you can develop orthostatic hypotension. This is the one where you feel lightheaded when you stand up quickly, or sometimes you can even pass out. Or you can have impotence, or you can have lack of sweating. So how do we diagnose peripheral neuropathies? I usually tell the medical students that work with me that you should get a very good history and be confident of your diagnosis in about 90% of the time and be correct about it. History is the single most important part of evaluation. And then the rest of what we do is really to confirm our clinical suspicion. We will do a detailed neurological examination, and then we may order some of these tests. Not everybody gets all the tests. Often we will start with a nerve conduction study and electromyography because it's a very good objective tool to evaluate the large nerve fibers, the motor nerve fibers and the large sensory fibers. However, it does not evaluate the integrity of the small nerve fibers that goes to your skin. So there are patients who can have small fiber involvement only without the large fiber involvement. So you may have neuropathy with normal nerve conduction studies, and you may be even labeled as crazy because the first doctor that you go says, can't find anything. You have burning, you have numbness, tingling. They do nerve conduction studies, it's normal, they say go away. But if you do this test, which is a skin biopsy, often it's a very simple test. We do punch biopsies. It's about a 3 millimeter in diameter, so like 1/8 of an inch, and we do 3 sides, and we can look under the microscope. We stain it for the nerve cells and actually count. We look at the shape of the nerve fibers and determine if it's degenerating or not. So this is the test that was actually pioneered by Johns Hopkins by one of our previous chairmen more than 20 years ago, and now has become really the standard of care in many of the major neuropathy centers. There's other tests that are used to evaluate your autonomic function. And I won't go into details of these. Rarely we will do imaging. This is really to rule out other diseases that can give you similar symptoms to peripheral neuropathy, but not necessarily help you make the diagnosis of peripheral neuropathy. For example, if you have pinched nerve in your lower back, that can give you weakness in your ankles. It can give you numbness or pain in your feet. And sometimes, we often can tell them apart from the nerve conduction study, but not always. So sometimes I will do an MRI scan of their lumbar spine to make sure that they didn't have something else. And back problems are unfortunately quite common in the population, especially as we get older. So this may be necessary in some people. Nerve and muscle biopsy are being done less and less, partly because skin biopsy really allowed us to evaluate the nerves without doing a more invasive nerve biopsy where you go in much deeper into the tissue and take a big chunk of a nerve. We still do the nerve and muscle biopsy if we're suspicious that the patient has inflammation in their nerves or in their blood vessels, because that's one of the few types of peripheral neuropathies that is potentially treatable with immunosuppression, with medication that suppresses the immune system. So this is done, but often though, the pattern of involvement that you determine from your history, examination, and nerve conduction study will tell you that the patient is likely to have that type of neuropathy, which we call mononeuritis multiplex. So I probably do a nerve or a muscle biopsy in less than 5% of my patients. So it's not that common. What's most important is really the blood work, because the blood work helps you understand what is the underlying etiology. Is it diabetes? And we often do a much more sensitive test for diabetes called the oral glucose tolerance test. So your fasting blood glucose may be normal, but people have trouble handling the glucose load or sugar load that comes with meals. So that test is much more sensitive. And rarely we will also do spinal tap to look for inflammation in the nerves. So what are the common causes? As I said, diabetes. Inherited neuropathies are not that common, probably 2 to 3%. Other acquired causes. The big ones are here: chemotherapy, toxic, and when we talk about the toxic, it's not the heavy metals or common toxins in the environment. These are often really simple things. Do you know what's the biggest toxin for peripheral nerves? What's the most common? Alcohol. So people tend to ignore this, but and again, not everybody who drinks alcohol heavily develops peripheral neuropathy, but if you have the genetic susceptibility, and if you drink 2 shots of whiskey every night for 10 to 20 years, I can guarantee you're going to get a neuropathy. And often what happens in these patients is that they will have a very mild neuropathy for many years, and all of a sudden it takes off and affects their balance. That's the big one with alcoholic patients. So and these people are not traditionally alcoholic people who are getting drunk constantly. It's just the chronic use of alcohol can be bad for the peripheral nerves. And the other thing is, even if you have a neuropathy from another cause, let's say you're diabetic and you have diabetic neuropathy, if you drink alcohol heavily, I can guarantee you that your neuropathy is going to be a lot worse. It will progress much more rapidly. Yes?
What about wine and gout?
So wine, I think in moderation is perfectly fine. I usually tell my patients a glass of wine with dinner is okay. But if you have a neuropathy, I usually tell them to cut that to maybe no more than 2 or 3 times a week, if you have a neuropathy from another cause. Wine by itself, unless you drink like a bottle every night, you're not going to get it. Okay. So other causes of neuropathy, this is a relatively rare condition called paraneoplastic. That is, you have a type of a cancer. This is often with lung cancer. Your immune system is fighting the cancer and literally makes a mistake and attacks your nerves, and you can get neuropathy from that. Infections, the big ones are HIV in this country. Often leprosy is the biggest one in the rest of the world. Lyme in certain areas, but Lyme neuropathy is relatively rare because often if you treat the underlying Lyme disease, you don't get neuropathy. Tuberculosis can also cause, but hepatitis is another one. A big category in this group is actually other autoimmune diseases. And what I mean with them is a lot of the rheumatological diseases. For example, rheumatoid arthritis, Sjogren's, lupus, Wegener's granulomatous. These are all different types of rheumatological diseases that normally affects your muscles, joints, and your connective tissue, but can also affect your peripheral nerves and cause damage. Often if you treat the underlying rheumatological illness, you can slow the progression of the nerve damage, maybe even stop it. So it's very important to make sure that the patient doesn't have an underlying rheumatological disease. So what I thought I would do in the next few minutes is give you 3 patients that I've seen in my clinic that kind of gives you a flavor of what we see in the clinic. This was a 61-year-old woman who was complaining of a burning feet for about 3 years. The onset was very slow, and her symptoms were worse in the evening. And that's also very typical of majority of people with peripheral neuropathy. The reason for that is during the daytime, even though those nerves are constantly sending impulses to the brain, your mind is occupied, you're running around, you tend to ignore it. But the moment you sit down to watch TV or trying to go to sleep, all of a sudden those abnormal sensations become much more bothersome. So that's very typical. So this patient's examination was relatively normal, except that she had decreased pinprick sensation. She couldn't feel the light touch and temperature up to the ankles. Typical stocking distribution, and her reflexes were normal, except the ankles were slightly reduced. So nothing major in this exam. But when we did, and her nerve conduction studies were normal, suggesting that her large nerve fibers were healthy, and they were not affected. She didn't have balance problems. She didn't have any autonomic symptoms. She didn't have any muscle wasting weakness. But then when we did her skin biopsy, we found that so this is a normal skin biopsy. These dark thread-like structures are actually the nerves so this is your skin. This is the epidermis, this is the keratin layer. And in this patient, what you're seeing is that you get these swellings. And if you notice, the number of these nerves are less compared to this side. So this patient had small fiber sensory neuropathy. And when we did her blood work, we found that she was pre-diabetic. So oral glucose tolerance test was very important in making that diagnosis. And in patients like this, catching the pre-diabetic state early on is very important, because with good lifestyle changes, diet, a little bit of a weight loss, and exercise, you can actually delay the onset of full-blown diabetes and also slow the progression of the neuropathy. So how do we diagnose people with small fiber neuropathy? As I mentioned, skin biopsy. Majority of these patients are also diabetics or people with impaired glucose tolerance. And the treatment, and I'll come back to the treatment, but it's similar to the other type of peripheral neuropathies, because most peripheral neuropathies, by the time the large fibers are involved, small fibers are almost always involved. So with other peripheral neuropathies, you get the same type of symptoms, so you use either anti-epileptic drugs such as Lyrica, gabapentin, or you use antidepressants such as amitriptyline, which is also known as Elavil, or Cymbalta, and so forth. So that was one type of a neuropathy. This is another type of a neuropathy that is often considered a neurological emergency. These are not the patients who present very slowly. This was a 50-year-old man. He initially had some tingling in his feet, and 3 days before he presented to the emergency room, he was stumbling. He had trouble walking. He had acute onset low back pain, which he didn't have before. And then by the time he was seen in the emergency room, he had weakness in his hands, he had trouble breathing, and he had a diarrheal illness 2 weeks earlier. And on examination, as you can expect, if somebody has weakness complaint, he had diffuse weakness that affected both his proximal and distal muscles. He had a patchy abnormality in his sensory examination, and his breathing capacity was reduced markedly. So in a normal person, this should be about 3 liters or more. His was 1/3. So these patients need to be admitted to an intensive care unit and very closely monitored. Usually in these patients, unlike the small fiber neuropathy, the nerve conduction studies will be abnormal. You get a problem that's in the insulation. Okay, the myelin is abnormal. The electricity don't conduct in a uniform fashion, but it's conducted in a broken manner. Often these patients have abnormalities of protein in their spinal fluid, increased protein, and because of their diarrhea, they have a bacteria called Campylobacter that causes the abnormal immune response. So in these patients, what happens is your own immune system, while it's attacking the bacteria, literally makes a mistake and attacks the nerves. The reason for that is one of the bacterial proteins on its coating on the outside of the bacteria has a structure very similar to the myelin, the insulation around the human nerves. And that's the reason our immune system sometimes makes that mistake. Obviously, not everybody who gets a diarrheal illness with this bacteria gets Guillain-Barré syndrome, that's what this disease is. So there's clearly some genetic susceptibility issues. And then the third patient is somebody who had almost a lifelong problem. She was a young woman who used to trip and had frequent falling. So what are those symptoms indicate? Clearly weakness of their foot and ankles. Frequent falling is either from tripping or from their poor balance, so their large fibers, motor fibers are affected. The onset was very slow. Often these patients who have a lifelong problem, they don't have a lot of the positive symptoms of acquired neuropathies. They don't get the tingling, burning pain, or prickling sensations, but they may get cramping. Family history was we couldn't obtain because she was adapted. And these patients often have very unique features in their feet. They have what we call high archers and hammer toes, and I have a picture of that in a second. You could even palpate their nerves that are in their hands or behind the ears, because those nerves over time, because they have this thing since birth, slowly enlarge. This patient had what we call Charcot-Marie-Tooth disease type 1A. This is what high arch and hammer toes will look like. They often have very thin legs, especially below the knees, and their hands are also thin and atrophy, so they have trouble opening jars, buttoning, and so forth. And their nerves in their neck can be enlarged. And if you look at their nerve biopsy, which we don't nowadays do because we have genetic testing, this is a normal nerve. These are each individual nerves. The white areas are the axons, the black areas are the insulation. Their nerves look very different. They're reduced in numbers. The myelin-making cells often wrap around the axon many times, which somebody more than 100 years ago termed it onion bulbs. I think it's a good description. So how do we treat peripheral neuropathies? Often, if the problem is in the myelin, that is, if this is an autoimmune problem where the immune system makes the mistakes and attacks the nerves, we can treat that with immunomodulatory or immunosuppressive therapies. The most common, so the disease that typically we deal with is either Guillain-Barré syndrome, which is often an acute illness. There's also a chronic form of that. It's called CIDP, chronic inflammatory demyelinating polyneuropathy. Okay. It's, on one hand, it's lucky because it's potentially treatable. On the other hand, unlike most others, it can also be very severe and can cause marked muscle weakness and wasting as well. So a correct diagnosis is very important in those patients. The reason is, even though we can't make the nerves healthier faster, the moment you suppress the ongoing immune attack on the nerves, on the myelin, the body can actually repair the myelin. The body can't repair the axon very well, but it can repair the myelin very efficiently. So these drugs, like intravenous immunoglobulins, which is a blood product that we infuse once a month to patients, or medications that are kind of mild chemotherapy drugs. They suppress the immune system but not completely wipe it out, like the chemotherapy, or prednisone, which is a steroid that we use often for these patients. So the goal is to suppress the immune system long enough that body can repair the insulation around the nerves. However, for axonal neuropathies, we don't have any drug that can actually make the nerves regenerate yet. There's been many clinical trials, many research. I mean, believe me, big pharmaceutical companies probably spend orders of 20 to 30 billion dollars over the years and still haven't come up with a drug. Part of the challenge is, unlike any other nerve cell, think about it, these are skin cells, your liver cells, they're tiny, whereas a nerve cell is so long, and maintaining that nerve cell requires very complex machinery within the cell. And damage to that cell isn't easily repaired because it can't bring all the parts that it needs to fix the problem that's happening away from the cell body. One thing that is gaining a lot of attention in the scientific literature is really the exercise, role of exercise. This initially started from animal experiments where we can make rats or mice diabetic and then put them on a treadmill every day for about an hour and ask, do they develop to the same degree of neuropathy? The ones who are exercised, their neuropathy is less severe, clearly, often 50% or more less severe than the ones who are not allowed to exercise or forced to exercise. You could also test whether the exercise has any effect on nerve regeneration. And this has been done again in rats. For example, if you take a rat and crush their sciatic nerve, this is the big nerve in your leg, and put them on a treadmill, the ones that are forced to run on the treadmill regenerate their nerves twice as fast as the ones who are not exercising. So right now there are 2 large clinical trials ongoing in patients with diabetes to find out what is the optimum type of exercise that we need in patients to see if it has any effect on humans. We don't have firm data yet, but in the absence of that, while we're waiting for those clinical studies, I usually encourage my patients with peripheral neuropathy to exercise at least about half an hour every day. You have to be careful though. For people with peripheral neuropathy, jogging is not a good idea. I'm sure you all know. You're going to feel the pain a lot worse after you run. But non-weight bearing exercise is what you want to do. The best non-weight bearing exercise is swimming. So if you have access to a YMCA pool, get in the pool, even if you're not a swimmer, you can put a floaty and just move your arms and legs. What we learned from the animal experiments is that when you exercise, your muscles release certain proteins into the blood. These are what we call growth factors or neurotrophic factors. So they are good for the nerves. And even the muscles that are away from the damaged nerves are releasing these proteins into the blood. And those proteins go to the nerve and try to keep it healthier. Obviously, swimming is not very convenient. The second best type of exercise is a stationary bicycle. Because again, you don't want to be on your feet putting a lot of weight. Walking is okay as long as you don't have too much pain and you do it safely. If you have a lot of balance issues, probably walking is not the best exercise. But stationary bicycle is something you can all do, just watching TV. And obviously exercise has all sorts of other benefits. One of the other important things that people tend to ignore is preventing other causes, secondary causes of neuropathy that can make it progress more rapidly. So let's say you have, as I mentioned, like diabetic neuropathy. If you drink a lot of alcohol, your neuropathy is going to be worse. Or you have idiopathic neuropathy, or you have inherited neuropathy, and all of a sudden you develop diabetes. And now your neuropathy is going to progress a lot more rapidly. So you want to kind of mitigate a lot of the secondary things that can make the neuropathy progress more rapidly. So how can we control the symptoms? So if we can't fix it, if we cannot treat the underlying problem, is there anything that we can do to help patients, make patients' life more comfortable? So we can't fix the numbness because numbness comes from complete degeneration of the nerve. And often numbness is not what bothers the patients. I mean, they often kind of learn to live with it. It's the positive symptoms, the pain, the prickling, the burning, and so forth that becomes bothersome and affects their quality of life. So we treat these with 3 or 4 major classes of medications. And unfortunately, as Pam mentioned, none of these drugs work in everybody. There's no magic drug. It's truly a trial and error that you have to work with your doctor. You start with one and then push the dose up until you have either side effects and you can no longer take it, or you have benefit. And if there's no benefit, you stop and move on to the next drug. It's truly trial and error. And there's really no rhyme or reason for why patient X has response to Lyrica and patient Y has a response to Cymbalta. It's very difficult to predict. The only ones that I usually start with Cymbalta are people who feel a little bit depressed. So when you have chronic pain, it's very easy to develop what we call reactive depression. So with medications like Cymbalta, you basically can treat 2 things at the same time: help with their mood a little bit, and also it helps with their neuropathic pain. And sometimes we combine these medications. So some of you may be on 2 or 3 different medications at the same time. For example, a good combination that I often use is where you pick one drug from the anti-epileptics, like Lyrica or gabapentin, and if the patient has a partial response but still have trouble falling asleep at night, I will use a low-dose, older antidepressant called Elavil. One of its side effects is it makes people sleepy. You take it once a day in the evening around 2 hours before going to bed. So combining that at a low dose so that you don't have a lot of side effects with an anti-epileptic drug is a good starting point for people who have a lot of pain, especially who have trouble falling asleep. We tend to avoid the opioid drugs, narcotic drugs, because what happens is once you start using it, your body gets used to it. The nerve cells that respond to opioids downregulate what we call the receptors for. So for the opioid drugs, the narcotic drugs to work, it has to bind to a protein on the cell surface. And then it basically suppresses the electrical activity or the pain centers. But what happens over time is your nerve cells in the brain, in the pain center, makes less of that protein. So you're going to need more of that narcotic to get the same effect. And all of a sudden your brain is downregulating, you need more and more of the narcotics, but the narcotics also bind to different proteins in your gut, so you develop constipation. That's a big problem with opioid drugs. So you tend to develop a lot of side effects and need longer or higher doses with opioids. But in few patients, that's the only thing that helps them live a reasonable life. So it's always a balance between the side effects and the potential benefits. I encourage my patients to try other things that are non-pharmacological. I mean, there's really no downside to any of these. They're harmless often, as long as you do it carefully. They can help with your mood. They can help you cope with the difficulties that you have with the neuropathy. And for example, biofeedback is something that's often done together initially with a psychologist. They teach you how to, and it's a mind control over body. They teach you to calm down when you have a lot of pain and suppress that painful sensations. Tai Chi and yoga tend to help people with their balance. So when I have a patient that has a lot of balance problems, I will initially send them to physical therapy for what we call gait evaluation and balance training. There are sets of exercises that you can do to help your brain cope with the limited input it's receiving from your legs to maintain your balance. I always get this question of, will acupuncture help me? The data on that is really mixed. And I tell all my patients, if you want to try it, if you believe in it, go ahead and try it, but don't expect miracles. So acupuncture has been tested in diabetic neuropathy patients and patients with HIV neuropathy in a Western-style clinical trial where they put the needles into quote-unquote false or placebo spots. Patients some of the patients received acupuncture that wasn't real, some had the real. And out of 4 studies, 2 in diabetic, 2 in one was, 2 of them had a positive response, that is, it was better than the placebo, and 2, there was no benefit. So, as long as the insurance covers it, it might be worth trying it for maybe a couple months, and if it benefits you, even if it's a placebo effect, it's probably beneficial. At least it doesn't have the side effects as these drugs do. In some patients, I will use topical medications. This is often helpful only for people who have very focal problems. So sometimes people with peripheral neuropathy, especially at the beginning, just may have burning in the bottom of their feet or in their toes. So that's a limited area that you can use a cream or lidoderm patch. So lidoderm patch is similar to what the dentist uses for your teeth. It's a numbing medication. It's a local anesthetic. And you put it for 12 hours on, 12 hours off. It works in some people. Capsaicin is the ingredient in hot pepper, chili pepper. So it's kind of counterintuitive, but what it does is it actually kills the nerve cells. The nerve cells that are constantly sending impulses to the brain. So it suppresses those and it partially kills them. It's difficult to use because at the beginning, often the patients have increase in their pain because you're killing the nerve cells and the nerve cells are very active. But that goes away after about 3 to 7 days. So if you can kind of bear that, some patients find benefit from it. But you can't use it in people who have a much more widespread neuropathy. So I think this is my last slide. So what I thought I will do is talk a little bit about the ongoing research. As Pam mentioned, one of the things that we started with the foundation is this Peripheral Neuropathy Research Registry. So, as I said, we have about 30% we still classify as idiopathic. We don't know what caused it. Our goal is trying to identify new causes by examining patients' blood, doing careful examinations, and reduce the percentage of patients that are labeled as idiopathic. Maybe we can identify either genetic susceptibility issues in those patients, or maybe we can identify some environmental factors that's been missing. One of the 2 recent findings is that high lipid levels, so cholesterol, elevated cholesterol. We never thought that it was really related to neuropathy, but recent research in the last 2 years showed that even though it may not cause neuropathy, but if you have diabetes and you have diabetic neuropathy, people who have high cholesterol, their neuropathy is often twice as bad as the people who have normal lipid levels, normal cholesterol levels. So you could have 2 or 3 different things contributing to your neuropathy.
Excuse me.
Yeah.
When you say high cholesterol, is it the LDL or the HDL?
So it's the LDL. That's the bad cholesterol.
If you have high HDL,
that's
is that
actually
a good
good.
thing? And that would prevent or help with the peripheral neuropathy symptoms?
That we don't know.
That
hasn't been looked into it. The part that's also really bad for neuropathy, this is from Dr. Eva Feldman at University of Michigan, her work, triglycerides. So when we talk about lipid, your doctors will order a lipid profile that measures total cholesterol, good cholesterol, HDL, bad cholesterol, LDL, and also triglycerides. And so those 4 things that are measured, triglycerides has the highest risk factor for worse neuropathy, followed by the high levels of LDL. The other thing that many pharmaceutical companies or biotech companies are working on is trying to come up with better symptomatic therapies. We definitely need drugs that work in more patients and work with less side effects. When I was a resident, we didn't even have Lyrica or Cymbalta or Savella. These are relatively new medication in the last 10, 15 years. So there's clearly a lot of research going on in this area, and we're hopeful that new drugs will come out in the next 5 to 10 years. What we're focusing is really these two areas, and when we say we, I mean not just my laboratory, but also other academic centers, trying to understand and come up with treatments that are really directed at the underlying mechanism of a specific type of a peripheral neuropathy. For example, if you have diabetic neuropathy, if we can figure out how diabetes or high sugar levels cause nerve damage, then we can block that step and hopefully prevent progression of the neuropathy. So those are pathogenesis-directed treatments. Or for example, chemotherapy. That's an ideal situation for developing a drug for that, because here you know that a patient is going to get chemo. You can actually intervene before the toxic chemical is given to the patient. And that's a big area of research, both in my laboratory and many other laboratories. And finally, the pharmaceutical companies are getting interested in this, because we can only do so much in the laboratory and academic center. Often developing our findings into a real drug that can be tested on patients require millions of dollars, and it needs a big pharmaceutical company involvement. Many of the groups and our own laboratory research that's partially funded by the foundation is trying to come up with regenerative treatments. And what I mean by that is, regardless of what caused the nerve problem, whether it's diabetes or something else, if we can understand how the nerve regenerates. So unlike the central nervous system nerve cells, the brain cells, the peripheral nerve cells have the capacity to regenerate. It's just they don't do a very good job. And often it's blocked because of the ongoing underlying cause of the neuropathy, like diabetes and so forth. So our laboratory is trying to test new drugs that can speed the nerve regeneration and also come up with the better understanding of the molecular mechanisms how the nerve fibers regenerate.